We found Seamus Heaney of Mossbone, County Derry, in the port of Kalamata.
Aren't wrongs all relative things?
Tommie Gorman, RTE News, Stormont.
A working life flies past. My last broadcast as RTE's Northern Editor was at the end of a busy Sunday. When I think of the Derry I went to in 1980 and the Ireland I see now, north and south, it's a better place. The killing has stopped. And I think the likes of Arlene Foster and Michelle O'Neill and all the other parties in the Assembly and south of the border, they are committed to trying to make things work, and that's the job I leave behind. For my successors, they have a busy time ahead, but I still think it's an Ireland that's full of hope.
Well, Tommy, you don't sound like a man who's ready to hang the notebook up just yet, but I do hope you get to put your feet up a little. But on this, your final broadcast with us here on RTE, it would be remiss of me not to thank you on behalf of all of us here in RTE, on behalf of all our viewers, for your integrity, your journalism, your friendship and your wisdom. Tommie Gorman, our Northern Editor, goodbye, and goodbye for now, and thank you.
Thank you. Wow. Well, that's my final broadcast as RTE's Northern Editor from this balcony. But before I hang up the microphone, there's one other piece of work I'd like to do. It's 20 years since I made a documentary called Europe, Cancer and Me, about my experience of living with cancer. And I'd like to maybe try to make a programme to update that story. If we do it right, if we do it honestly, maybe it'll be a programme that'll give some hope to people. And we're going to give it a working title, Ireland, Cancer and Me. Roll back the years. This is material from that documentary that told how my cancer journey began in January 1994. I was in my 5th year as RTE's Brussels correspondent. I was 37. We'd come back to Belgium with our 9-month baby daughter after Christmas in Ireland. I was admitted to the emergency department of a small hospital 45 minutes from Brussels with a suspected appendix problem. It turned out to be a lot more.
We had the surprise to find some small lesions compatible with metastases in the liver, and after that we searched for the primary, and we found a small lesion, small nodule in the small bowel.
It was a small little oratory downstairs, and I used to go down there, and it was the kind of environment where you could actually start putting things in context for you. And I suppose it's a difficult thing to understand, but when you're in that kind of a corner, a year seems an awful long time. 5 years seems an eternity. And of course, what you're doing is you're listening to the most positive pieces of information that are coming to you, and you're filtering those.
The Belgians found I had a rare form of cancer called NETs, neuroendocrine tumours. In Ireland, an estimated 1,500 to 2,000 people have the disease. They took out the lump, causing an obstruction in the small bowel. They decided to monitor the problem in other areas, one lymph node and the multiple tumours scattered like pepper and salt on my liver. A scientist based in the German city of Heidelberg took a different view. I met him by chance in a bar in Budapest. He was from my hometown of Sligo.
When I read what I read, I had a shock. Because instead of something, minor, benign, uncomplicated, it will go away, nothing to do, I was reading things which had statistics that said something like, on average, a 5-year lifespan, immediate surgery recommended, patients' aid groups, survivors' aid groups, statistics that didn't stretch very far because they hadn't been gathered very far, because the disease was one which didn't have a long lifespan following discovery, etc.
I now trawl the internet, first to New York, then to Sweden.
My email for help got an instant reply. I was off to Uppsala, to a hospital and a man who'd become crucial to my well-being. For someone with my rare condition, Kjell Åberg's clinic was as good as Aladdin's cave. He had been dealing with carcinoid tumours for 20 years. We broached the kind of future I faced if I didn't get the help of his team in Uppsala.
You had a tumor progression, a constant tumor progression over the next few years with more severe symptoms, more flushing diarrhea, and more liver metastases. And finally, without any significant treatment, you get bone metastases and in the end also brain metastases. So that's the usual development of this disease. It's also a risk to develop carcinoid heart disease, which is a rather severe condition where you get defect of the heart on the right side.
To help stop the spread of the disease, Åberg immediately put me on a drug called interferon. It's heavy artillery. Like my friend Frank Gannon, he was puzzled that the lymph node had not been removed. It was now time to address this lymph node problem with one of Åberg's colleagues, a surgeon at the hospital. I was very nervous about what he might say.
You cannot get rid of the disease. We can keep it where it is, and we can postpone any problems with it. That's our feeling. Especially the lymph node in the there. That's number one. And for treatment of the liver, we can also postpone any bad liver function, for instance. With how much we don't know because it's fairly new, but so far it's very good.
When you say postpone, have you got a time frame in mind?
Yeah, that's what I mean. We don't know for how long, but maybe 10 years, something like that. There are patients that we can actually treat the liver so we don't see anything more, but the scars after the treatment. And then we just have to wait. We don't think that we have treated the patients completely, that they're out of disease. It might be that 2, 3, or 5 or 10 years later, a new one comes up. Then we can treat that again, of course. But if you leave them there, you're stuck with interferon or sandostatin, and then to keep them there, it might shrink, but eventually they might also increase. We really don't know the answer, how long we can postpone complications. But
it sounds like you're talking about postpone until the next treatment rather than postpone until death.
Yeah, that you can say. Postpone until next treatment.
So it sounds like I'm not going to die from this thing for a long time.
No, you seem to be very fit right now, and if we can keep the liver where it is, or even make it a little bit better, you're not going to die from this for a long time. That's true.
How long?
That's a very difficult question. How old are you now?
43.
43. So that would be, well, at least 20, 30 years, I think.
That long?
Yeah. But no one really knows the answer.
Sometimes journalism can be a shield. At times I told myself I was on a story with deadlines. Sometimes, too, a piece of a jigsaw can emerge miraculously. I had been covering the Court of Justice, where a Luxembourg man sought reimbursement for a pair of glasses he had bought over the border in Belgium.
Everybody speaks about freedom of movement of goods, freedom of movement of services. And this is perfect for companies. This is perfect for everybody. Why shouldn't it be? Why shouldn't patients have the same rights to see their doctor in another country and be reimbursed by their sickness fund?
That resourceful Luxembourger established the right in the EU's Court of Justice for EU citizens to access healthcare in another member state. We've come to know the E111 as the facility to get us access to help if we have an accident when on holidays in another EU country. The E112 opens the possibility of accessing a health procedure or treatment in another member state. Provided it can't be got in one's home country, it is cost effective, and the proposal is backed by a consultant in one's own member state. I went in search of a surgeon in Sligo, my hometown, to help me.
I obviously recognised that it was vital for you, a young man, that any opportunity for the best possible treatment should be grasped, and that's how I responded, you know. You convinced me that it might be a worthwhile role. Certainly, I felt I should, as it was necessary for me to facilitate such a treatment by introducing you to it, it was certainly, I felt it important that I'd facilitate that I wouldn't hold back on it. I had nothing better to offer.
On the recommendation of Surgeon Peter Morrison, the then Northwestern Health Board issued a NE 112 form for me. I was the first Irish patient to be given what was effectively a guarantee of payment for the hospital in Uppsala.
Easier to take a bus or take a bike or
May is the month of both my father and mother's birthdays.
Today?
No, this month.
Aha.
So it's a nice month.
Herr Hellman hoped he could remove the troublesome tumour, but could give no guarantees. He also explained that, all going well with the surgery, he'd use some of my time on the table to carry out a closer investigation of the state of my liver.
You understand what I say? Operation went fine. You did not have any tumor in the small intestine, but you had the lymph node we talked about. And that's taken away now. We had to take a part of the small bowel too, otherwise it would have been impossible to take this lymph node out. But you have plenty of small bowel left. It's going to be absolutely no problems.
How was the prognosis?
It's good. You have this type of tumor that grows very slowly. We have taken away the risky parts of the tumor, which are connected to the gut and the mesentery to the gut. Now the treatment in the future will be for your liver. And that treatment you can have for decades and decades and decades and keep the tumor staying there. Right. So it's a good prognosis for you.
Was it that you expected?
Yes, it was. It was as I expected.
Up the rovers. It looks beautiful. Beautiful.
That's the surgeon's view.
Everything is right.
No pain here?
Not that side. Pain is on the right side.
You had some pain here?
Yeah.
There's him.
Yeah. There. Yeah.
Yes. When I touch very gently, also cause some pain.
It's when you push it gets
Yes.
it.
Yeah. So I think that's superficial.
As we discussed, there are some new therapies also, like radiofrequency treatment, going with this needle, ultrasound guided, and burn the tumors off, which can be applicable.
With luck, have I got a fighting chance, a very good chance, or how would you describe my chances of having a normal life?
I can't guarantee anything. But with the therapy today, we can control the disease very good, also. Very well. And you'll have a normal life with a almost normal numbers of years of survival, or normal. I mean, I can say that 100%, but that's my estimate.
I was on my way home to recuperate, helped by my former boss, Joe Mulholland. As Surgeon Per Hellman predicted, I would need to come back to Uppsala a number of times for more treatment. Hundreds of Irish patients with the same disease followed my example. We were accessing care and procedures that were not available in our own country. But in Ireland, I began meeting with doctors and administrators who were keen to change that.
It was a stark landscape. We were dealing poorly with people who had neuroendocrine tumours, even those that were in our care in St. Vincent's, because the nature of the imaging that was required, the blood tests, the urine tests that you needed to be running weren't established. So that's not an infrastructure for making good decisions and getting the best outcomes.
The major dangers of excess caffeine in children is...
Donal O'Shea is probably best known for his work to tackle the obesity problem in Ireland. He is one of the experts on the Operation Transformation television series. He was one of the first medics to speak in favour of setting up an Irish centre of excellence for patients with neuroendocrine tumours.
It was fairly clear we needed to do something. St. Vincent's had been identified as a national centre for liver disease. These tumours present predominantly in the liver. So we were seeing increasing numbers of people with this relatively rare neuroendocrine tumour, and we didn't have a system. And all cancers are best managed within the setting of a multidisciplinary team with shared decision making. So we had to go about building that.
There's a tradition on many levels of Cork looking with a jaundiced eye towards Dublin. Capital of the universe clashes with second city syndrome. But two consultants at Cork's Mercy Hospital were on the same wavelength as Donal O'Shea and his like-minded Dublin colleagues. Surgeon Christopher O'Sullivan and oncologist Derek Power became a progressive force in the development of services for patients like me.
I had an interest in neuroendocrine tumours already from previous positions that I'd held, and I was very lucky that I fell in with a bunch of other consultant colleagues who had also an interest in this. And obviously, as the practice started growing, more and more patients with neuroendocrine tumours were beginning to present to the hospital.
In October 2011, Christopher O'Sullivan and Derek Power organised a conference on the treatment of neuroendocrine tumours at University College Cork. The speakers included international authorities on the disease. One of them was a Carlow-born gastroenterologist, Dermot O'Toole, who was working in France at the time. That UCC conference further convinced Donal O'Shea who might best lead the transformation of NET services in Ireland.
At that time, I was reading the European guidelines for managing these tumours, and there was a name kept popping up at the beginning and at the end of the guidelines, and when I went to talks in Europe, Dermot O'Toole was presenting the revised guidelines for the European Neuroendocrine Tumour Society.
St Vincent's Hospital in Dublin was identified as the best place for a national centre of excellence for NET's cancer. It was building a team with an expertise in dealing with the disease. But there was a problem. Dermot O'Toole, the likely best person to lead the new service, was back from France, but working in St James's Hospital. A Berlin Wall-like challenge would have to be addressed.
A shared appointment between St James's and St Vincent's was unprecedented, and it involved really high-level commitment within the Department of Health, the National Cancer Control Programme, and the two institutions to allow it to happen. But when there is an obvious move to be made and the reasons are strong, then people see the sense of that. so they made it happen.
For NETS cancer patients like me, this was an important day. A formal announcement of the person to lead the running of the fledgling Centre of Excellence.
I think in terms of announcements, we were absolutely delighted to be able to say that Professor Dermot O'Toole, a gastroenterologist at St James's Hospital and a member of the academic staff at Trinity College, has actually accepted being appointed as the National Clinical Lead for Neuroendocrine Tumours. Now, I think what is really important to understand is that this is the start of the development of a national neuroendocrine network.
I think that all of the patients have to be managed, that is diagnosed and treated and looked after according to absolutely the best international standards. We know what some of those standards are. Some of us are involved in defining them a little bit better, and we've got to put the Irish context into an international programme.
The expert to lead the transformation was in place. For patients like me, new options were beginning to open in our own country. We all had a shared interest in neuroendocrine tumours, a rare form of cancer. Ireland was starting to establish a centre of excellence model with links to other hospitals. It was in our interest to back and to help shape such improvements in our own country. In 2012, we formed our support group of patients, family members and friends. We named it the Net Patient Network. We have our own website to help the flow of information. Once a year, usually in November, we come together. It's always on a Saturday. That's because the doctors sacrifice a day off to be with us. Patients, their families, medics, the HSE, the pharma companies. A mehel that energises all involved. Shell Oberg, that doctor I met in Uppsala in 1998, was a guest speaker at one of our gatherings.
Of course, you are still welcome to Uppsala, and so we will not refuse to see you there. But I think it's good that it has developed so well here in Ireland, and you can get high-class care for neuroendocrine tumors.
If you are left alone with cancer, you are not finding yourself nobody to talk to. You know, but if you come out, you find, I'm not alone actually. There are people surviving, so I should also fight like them. You get to meet the physicians, you get to meet the nurse, you get to meet all the oncologists around, other friends who are suffering like you in the same boat as yourself.
Sometimes then those stones could become symptomatic, and that's why, you know, having had the gallbladder out at the previous surgery might be helpful. It might give the doctor a bit more of a comfort level that they're not going to get into trouble afterwards.
The patients, you know, they're clearly coming with something that they want to ask, and it's an opportunity for them to get something maybe they wouldn't get in a clinic generally. So I think it works very well. It's good opportunity for everybody.
At the Centre of Excellence at St Vincent's Hospital, the multidisciplinary team meeting once a fortnight became an important routine. Here, the different specialists combine their knowledge to track the patients under their care. As this new structure was being developed, I decided it was time for me to walk the walk. I repatriated my care from Sweden. I put my trust in the Irish system. It's 10 years since I was last in Uppsala. Retired school principal Tom O'Donoghue from Tipperary once followed my path to Sweden. Several times he received treatment there that was not available in Ireland. Like me, Tom now comes to St Vincent's every 6 months for care and maintenance.
Brilliant news for me. I didn't have to get on a plane, travel to Scandinavia and back twice a year, every year. And they were lovely over there and very good to me. But they're equally good here in St Vincent's. I love it here.
The satellite centres in Cork and Galway maintain solid links with the Dublin mothership. They are also building competence and trust in treating patients with the NETS condition.
This is a disease that invariably rumbles along with many hurdles over the years, and to be able to negotiate those hurdles and to be able to kick the disease down the road, albeit it's incurable in many cases because it's advanced, to be able to kick it down the road and maintain a patient's quality of life, I think that gives you a huge lift in your life when unfortunately I have to deal with diseases that don't do as well.
This former convent in Kilkenny is important for some of our patients group. It's where HSE staff deal with funding requests for treatment outside of Ireland. The E112 system I used more than 20 years ago to travel to Sweden is now known as the Treatment Abroad scheme. Each year, around 30 of our patients group receive authorisation to go for procedures to Uppsala, Rotterdam and London.
These are all treatments that are not available in Ireland, for which it's extremely important for the patients, for their quality of life, for their actual life.
Sligo surgeon Peter Morrison was unusual when he supported my application to travel to Sweden over 20 years ago. But Irish consultants across a wide range of areas are now availing of this EU directive to access procedures for their patients. Our cohort makes up less than 5% of those applications.
In any given year, we can have between 650 and 900 applications for treatment. Funding and the cost of a treatment doesn't even come into it. I came up through the system, in the old system, the old health board system. And the rules were you interpret the legislation to the greatest extent possible in favour of the patient. And that's the rules we still adhere to here.
A second EU scheme was introduced in 2014. It's known as the Cross-Border Directive. It was championed through the Brussels system by an Irish member of the European Commission, David Byrne. It complements the Treatment Abroad scheme. It is available to citizens who can't get care in the public system of our country in a timely fashion. They can bypass waiting lists by paying for treatment in a public or private hospital abroad and then seeking reimbursement from the HSE.
Treatment Abroad scheme for patients who can't access healthcare here in Ireland because it just simply isn't available here. The Cross-Border Directive for treatments like hip replacements, cataracts, knee replacements. A builder on a working site may be waiting 5-6 years to get the outpatient appointment and onto his inpatient care. He can do that within the space of a couple of months by using the Cross-Border Directive.
These Cork and Kerry residents were early beneficiaries of the Cross-Border Directive. Their local TDs, the Healy Rays and Michael Collins, were quick to understand the merits of the scheme. They helped their constituents to travel to Northern Ireland for procedures like cataract operations and hip replacements. A private hospital in Belfast was delighted to provide the service. Brexit should mean curtains for this arrangement, but the Irish government has introduced its own unique hybrid model to continue funding access to private care in the north. Last year, under the Cross-Border Directive, almost 9,000 people received reimbursement for treatment. The volume of applications for treatment on mainland Europe grows.
Ryanair, Aer Lingus, cheap flights, patients are travelling and they are travelling to where they can access healthcare in a timely manner. Patients living here from other countries, whether it's Spain, Italy, Poland, Czech Republic, they prefer to go home to have their healthcare. Nurses will go into nursing because they want to help people, but likewise administrative staff work in the health system because they want to help people and because that's where their love of their job comes from. We're really lucky in that we are administrative staff who get to talk to patients every day.
In pandemic times, 27 years after my cancer was first diagnosed, this is a snapshot of some of my fellow Irish patients with the disease. Mary O'Brien's care is managed locally at the Satellite Centre in her native Cork. She and her partner Owen voluntarily run a Facebook facility for our support group.
I know if I have a problem, we're only a few minutes away from the CUH. I can go in there if I need to. We can liaise with the Mercy if we need to, and then they can liaise with Dublin if it needs to. So everything is not done in a loop.
We left the Net Patient Network meeting in Dublin many, many years ago, and going down in the car, myself and Mary said, you know, what can we do? And we knew our skills, that what we could do was do something online, ask some people, you know, is it needed? And from there then, you know, we decided, yeah, we'll put the time in and do it. And we do it now on a daily basis, every morning, check messages, after lunch, check messages, and then before you go to bed, just quick look just to make sure there's no one in trouble.
County Meathbourne farmer Charlie Hastings is in his early 60s. He went to Sweden for treatment that's not available here. So his care is now jointly managed by Uppsala and Ireland.
Well, when I was diagnosed first with pancreatic and liver cancer, as you know, everybody thinks the worst and you think it's curtains. But when we realised it was NETs cancer and realised that it is treatable and very treatable, and to keep the tumour stable, it's a whole different ballgame, it's a whole different outlook on life.
Andrea Martin is a media lawyer. All of her treatment is being delivered through the National Centre of Excellence at St Vincent's. She understands she has a condition that won't go away, so the challenge is to manage it.
Well, I'm not trying to be Superwoman anymore, and NETs has woken me up to that. It's a condition, you learn to live with it, it makes you treasure life, particularly when some of our members in the Net Patient Network, we've lost 2 lovely people in the last year, and that happens. That happens in all walks of life, but NETs wakes you up to the fact that it does happen.
Mark MacDonald has used the pandemic to try his luck as a gardener. He is chairman of our patients group. He was recently elected president of the global body of NETs support organisations, the first Irish person and the first patient to hold the role.
We've improved a lot in terms of the access to NET specialists from around the country, where instead of being treated locally by maybe an oncologist, that there is now an involvement and engagement with a NET specialist from the nearest NET centre. And that, I mean, that really radically improves the possibility of a patient really surviving and doing well with this disease.
So what's the update on my story? For 20 years, every 28 days, I've taken an injection to help keep my disease at bay. It's like a monthly fill of petrol. You can feel the engine chugging towards the end of each month. I needed procedures in Sweden 6 times between 2008 and 2010. Since then, I've put my trust in St Vincent's. I come here every 6 months for a series of scans and tests. 4 years ago, it received formal accreditation as part of the European Centres of Excellence network. I still have a dodgy liver, peppered with tumours. There are signs of the disease at a number of other areas in my body. It won't go away. On judgment days like this, all that matters is that it remains stable. Upstairs in St Vincent's, the Zoom contributions are over. Another multidisciplinary team meeting in pandemic times is drawing to a close. There is one file left to be reviewed. It's mine.
So Lisa, while we're waiting for the imaging to load, is there any update here?
Some of the images on the screen are the results of a gallium scan. It is a new generation of medical imaging, providing better pictures with more information. For years, this system has been routinely used in Uppsala. 2 hospitals in Ireland are now providing the service. Vincent's and James's, both in Dublin. Radiologist Conor Collins describes evidence of the disease at different sites in my body.
Multiple sites of pathological avidity, multiple nodules of pathological avidity in both lobes of the liver. The arrow here is pointing to an added right internal mammary node, with further added nodes present in the epiphrenic area here adjacent to the heart. He's got an arrow here also pointing at an active peripancreatic node. This clever technique that we use with MR, you can appreciate the multiple sites or metastatic disease in both lobes of liver, which in fact is essentially stable since previously.
And any new sites of disease?
No new sites of disease.
Next patient.
So the dogs are asleep, they're behaving themselves. How long does that continue for? Are there any guarantees about that?
There are no guarantees, and the reason that we do regular interval scanning is that we cannot predict from person to person when the disease is going to change its mood and become more aggressive. And, you know, there's work being done to see, can we predict? But the biggest, I suppose the biggest thing we get over time is confidence. So when we sit down with people at the start of their journey and we say to them, we could be sitting with you in 5 years' time or in 10 years' time, but at the moment we don't know. And they have a tumour that's spread to their liver, they're looking at you and you can see in their eyes that they think, actually, he's really not being straight with me. And then 2 or 3 years later when they're sitting down with you and you're saying your disease is stable, they're going, you can see that they're getting confidence. But there is no accurate predicting and there is no guarantee about, you know, when and if the disease is going to change its trajectory.
In my case, it's 1994 when they found it, so it was there for a while beforehand. So as I see it, like, you know, I've won. These are kind of bonus years, you know. I didn't think I'd get this long. Is that a sign of defeatism or is it a sign of realism?
I think when you have a diagnosis of a tumour that has spread to your liver at a young age, that is going to cause a fundamental kind of just combustion of your thoughts on, you know, who you are, what's important, and when you come through that, you are a different person. So I would say you're neither optimistic, realistic, or pessimistic. I would say you're none of the three. You just are. And you are continuing to enjoy each year, each gap in between your scans. And, you know, I'm not sure what your reaction will be, and I'm not sure you know what your reaction will be if you are told in 2 years' time or 5 years' time that the disease has changed. You've probably been waiting for that at one level for a long time, and it hasn't happened. So I don't think you can gauge what your reaction is likely to be.
Is that you done, brother? That's me done. Thanks for all your help, and I'd say good luck to all your colleagues for me.
I handed back my press pass instalment last week. I will miss working in Northern Ireland. You become fond of the place. You'd like to see it more settled. But I keep reminding myself that the senseless killing has stopped, and that's a miracle of our times. Ireland really is a better place on many levels. The health service is one of them. Cancer, NETs included, is still killing people, but thanks to the Centre of Excellence model, many fortunate ones like me are managing to live with the disease. During 27 years, ducking and diving, I've seen the building of what is an Irish version of the Swedish model for patients like me. It is a work in progress. But if I ended a programme 20 years ago saying I'm grateful to be a European, I sign off on this one saying I'm proud to be Irish.